Hello, I'm Khaled Riyad, Professor of Plastic and Maxillofacial Surgery, Ain Shams University, Egypt. This is our Faculty of Medicine, and this is our university in Egypt, Ain Shams University. Today we're going to talk about maxillofacial surgery and maxillofacial fractures. We will cover the epidemiology and anatomy of the facial skeleton. But in quick, this lecture is for plastic and maxillofacial surgery residents and young fellows. It's not for people who are seeking extensive surgical details, but for bird eye on maxillofacial surgery and fractures, especially fractures. Definitely, any patient will come for you in emergency department with maxillofacial surgery, and you are consulted as a plastic or maxillofacial surgeon. You will do the initial assessment. The initial assessment will be primary survey, including history and physical examinations. This patient is subjected to a trauma to the head, and this patient might have other problems like brain insults or other body injuries, so it is dealt as a polytrauma patient or a post-concussion patient till proved otherwise. So we are going to jump this part and start the imaging for all maxillofacial patient with suspected fractures. We do CT protocol, and in some specialized or tertiary hospitals we do CT for many parts of the body, like CT brain, CT pelvis, CT facial, within the same setting. We are going to discuss also the fracture patterns and their treatments, and little about the complications and secondary procedures, and also little or very little about the complex reconstruction, as it is a very different setting from the trauma setting. Okay. First, epidemiology and etiology. Mainly, the etiology is motor vehicle collisions or motor car accidents. These are high energy and often have multiple fractures or multiple level injuries. Interpersonal violence, and this is less, also falls sports related trauma and occupational and industrial injuries, but most probably they are motor car accidents. The most common affected bone is nasal bones. They are mostly affected as they are protruding outside of the facial skeleton, very thin and not supported, so they are very commonly fractured. But luckily, they are not most of cases are not managed operatively, just splinting or just rest if they are not displaced. We are going to next sessions we are going to discuss this. The mandible is the most common site requiring operative management. Mostly mandible, especially in adults, need surgical management, even in maxillomandibular occlusion or in fixation by plate and screws. It's also most commonly in second to third decades, which are active and market predominance in males, fortunately. First, when we discuss the facial skeleton, it's not we will not discuss every bone and every articulation, but we have buttresses in the bone. What is meant by buttresses? Buttresses are bones with extensive thickness, more than other areas. These bones are like anchors or like heavy bones that can support the face, and their refixation if they are fractured is mandatory, as they keep the 3D configuration of the face. We have Vertical buttresses, as this image may show, we have vertical buttresses and horizontal buttresses. The vertical buttresses, we are going just now to show it, but the vertical buttresses, and there is a common mistake, is the facial buttress system. It discusses mid-face buttress system, not the whole face. When described by Lefort, the facial buttress system that was described by Lefort, he described the mid-face. So most probably you will find in books it's written nasomaxillary, zygomaticomaxillary, and pterygomaxillary. They are the vertical buttresses. Some books or some editions add the mandible, but it is not. Some say it's right and some say it's not, but the facial buttress system is for the mid-face. So we are talking about the mid-face, vertical buttresses, nasomaxillary, zygomaticomaxillary, and pterygomaxillary. The horizontal buttresses are the frontal bar, zygomatic arch, infraorbital rim, palate, and maxilla. Let's see it here. The human facial skeleton, we have the vertical buttresses, the nasomaxillary buttress, and this comes from the nasal bone and spans till the maxilla. The zygomaticomaxillary from zygoma and spans the maxilla. The pterygomaxillary, which is very posterior structure from the tragoid bone and supports the midface posteriorly. These vertical buttresses support the vertical length of the face. The horizontal buttresses are the frontal bar, here, the supraorbital bar or the frontal bar, the infraorbital rim with extension into the arch, then the maxillary here, the maxillary and palatal or maxilla or palate posterior. As a general principle, we must reduce and fixate the buttresses in its normal position, and if there is a gap, we should reconstruct by gap plates, or we can put small bone grafts if available. So these buttresses are very important in the facial configuration, the 3D facial configuration, and its length and width and even its depth. If the vertical buttresses or the horizontal buttresses go deep, like telescoped inside, it may cause depression. Okay. As we talked earlier, the primary survey in facial trauma, first we manage the airway. The airway is very important because all of the maxillofacial bones surround the airway, either the nasal or oral airways, so these should be protected. And we have special types of fractures like bilateral mandibular, especially bilateral body fractures. Why bilateral body fractures? Because bilateral body fractures may displace posteriorly and with the tongue attached in between, the tongue may overlap and cover the airway and cause suffocation. Also, any flail segments, loose teeth and dentures may cause any aspiration, especially if the patient has a disturbed level of consciousness. The posterior tongue prolapse, as we said, especially in bilateral mandibular fractures. Okay, these are common or not common fractures, but may cause airway obstruction. Definitely breathing, we deal with this patient as a polytrauma patient or a post-concussion patient if the head is only injured or only affected. Circulation, disability following this, and definitely when we deal with the maxillofacial injuries, we must exclude any cervical spine or cervical vertebrae injury, as before you send your patient to the CT, you must exclude any cervical injuries, even by just pressing and assess tenderness in the cervical area, the posterior cervical spine, to avoid any hyperextension during CT that may cause any problems in the spine. We have emergencies, yes, we have emergencies other than the airway. First, the airway, we said before that we have special type of fractures like bilateral body or bilateral, some say bilateral parasymphyseal, but it's not dramatic or dramatically affect the airway as the bilateral body. Also, tongue base or tongue hematoma may obstruct the airway. Orbital or mid-face comminuted fractures, especially comminuted fractures, may predispose to severe airway edema. It's not about obstruction, it's edema. The edema, if it is slowly progressive or rapidly progressive, may cause airway obstruction also. Also, we have orbital or mid-face fractures. Orbital may press or may cause any eye injuries. So next, we're coming to this. So the airway, we must exclude any special fractures that cause airway obstruction. Unluckily, general surgeon or emergency medicine may not notice this, and you should prevent this by even doing an emergency arch bar, even with sedation to the patient, or simply you can hold the tongue to the lower lip by thread. It's painful and it's awful thing, but it saves lives. Okay, patients coming to you with these injuries, you should do suction to avoid any airway obstruction or aspiration. You may give oxygen. If the patient is not managed like this, he must be intubated to avoid even nasopharyngeal airway or complete intubation. In late patients coming with airway obstruction, you may jump to cricothyroidotomy or cricothyrotomy. It's an emergency. Stab in the midline above the isthmus and put very small thing like pen or something like pen tube or something like this, or tracheostomy if have option for this. Second thing is hemorrhage. Hemorrhage also may cause airway obstruction, or extensive hemorrhage may cause the patient to be shocked. This injury may be due to lacerations for the scalp, especially scalp vessels, may be maxillary artery, and this is an emergency. You must intubate the patient. You must put, definitely intubation will be submental intubation, or if it is clear, you may do nasal intubation. Definitely nasal intubation should be avoided except after you are 100% sure of no skull base fractures. This may cause more injury to skull base. So just submental and do MMF, maxillary artery, most probably maxillary artery injury. And it's very, the maxillary artery injury is very, very important thing that we must control. Most probably, maxillary artery injury may be controlled by maxillomandibular fixation. Just MMF can compress the maxillary artery. Head elevation with compression over the root of the neck, especially if the patient is coming in gunshot injuries. But if more than this and the bleeding didn't stop, just the external carotid ligation may be the only thing you can do. External carotid ligation. Also, any fracture may cause some bleeding, but it is controlled with packing or just some hemostatic agents. Okay. The facial fractures themselves are not an emergency, but their airway obstruction, hemorrhage, any CSF leak may be urgent, not emergency, urgent, and should be treated without delay. Okay. We come now to the orbital emergencies. The orbital emergencies, we have retrobulbar hematoma when the patient has sustained a blunt injury and has severe bleeding. That bleeding may cause retrobulbar hematoma, and we can know by proptosis with ophthalmoplegia. I mean by ophthalmoplegia, the patient cannot move his eyes either to either side or up or down. With proptosis, this may signify retrobulbar hemorrhage. Or orbital compartment syndrome. It's rare but may happen in severe comminuted fractures. The patient has pain proptosis with rapid decrease in vision. This may be due to compartmental pressure or severe edema. This needs lateral canthotomy. Also, retrobulbar hemorrhage may be managed if there is severe symptoms, may be managed by lateral canthotomy. And this is an emergency. You may do it in the ward or in the ER emergency room without waiting the patient to get up to the OR. Little things like avulsed primary tooth or permanent tooth. This is the avulsed permanent tooth. You can re-implant again if possible and protect the airway also. Soft tissue injuries like crushing injuries or large injuries. You may have nerve injuries like facial nerve injury. They are urgent and should be managed without delaying the patient. TMJ, especially dislocation. Dislocation, it's not an emergency, but the patient cannot close his mouth and must first, before you embark on going to reduce the TMJ dislocation, to be sure that this is not a fracture. Clinically, there is no severe tenderness, there is no edema, but if you suspect fracture, you should do CT first. Okay? Now you must examine the patient. First, history is very important. Points, age, smoking, any previous operations, comorbidities, diabetic, hypertensive, any cardiac conditions, any previous surgeries in the mandible, in the maxilla, anything like this. Physical examination. First inspection, you should see the facial symmetry or asymmetry, any lacerations, ecchymosis, and we have a specific picture called raccoon eyes. Raccoon eyes are black eyes. They most probably signify blowout fractures or orbital fractures, as the hematoma is limited by the septal attachment to the periorbital, so it doesn't go down. Mastoid ecchymosis, and this is called battle sign, suggestive of skull base injury. You find ecchymosis on the mastoid. Also, globe position, ocular movement or mobility, visual acuity. These are very important things to monitor. Then by palpation, you just palpate with your thumbs and go around the maxillofacial skeleton from the supraorbital bar, infraorbital rim, maxilla, zygoma, mandible, all over the face bimanually at the same time to detect any stepping or discrepancy between both sides. Bone continuity and any tenderness. Any trismus, like the patient cannot open his mouth. Also cranial nerve examination, the ocular nerves, 3, 4, visual acuity, any thing like this suggestive of injury that may be superior orbital fissure syndrome or something like this. Facial nerve injury, we must see the whole branches of the facial very, very quickly. The eye examination, including pupillary light reflex, extraocular mobility. For subduction, it should not be tried on awake patient, and this is can be done with patient under sedation or general anesthesia to detect any entrapment. Intraoral examination is very important, and without intraoral examination, maxillofacial examination is not complete. You will see the occlusion, any new malocclusion, any hematomas, subungual hematomas, sublingual hematomas suggestive of mandibular fractures, any hard palate or soft palate injuries. Definitely imaging strategy depends mainly on the CT. CT is the gold standard. It defines the anatomical fractures, the pattern of the fracture, comminution, and aids in the management and treatment. We must have 3 cuts: the axial, coronal, and sagittal cuts. Sometimes we do 3D reconstruction for these. It aids in operative planning, and especially for patients' education. It's easier to teach the patient over 3D. He can understand other than axial or coronal cuts. There is a lecture about the CT. You can just see it. It discusses what are the cuts we need for every single fractures. And definitely post-operatively, it's better to get CT. Sometimes we do panoramic radiographs. MRI is done in eye injuries to exclude any disc or any problems around the disc or superior orbital fissure. Quickly, we will discuss now specific types of fractures. As we said, the nasal fractures are the most common fracture. It depends its classification on displacement and comminution pattern. Is the fracture displaced or not, and is it comminuted or not? Definitely there is something very important we must see in the nasal fractures. This is septal fracture or septal hematomas. Septal hematoma may cause cartilage septum resorption and necrosis, so it causes deformation of the nose. So it's very important to detect it early and evacuate with a stab incision through the mucosa without definitely injuring the cartilage. The ZMC fracture or the Zygomaticomaxillary complex fractures, we will discuss the classification later on, and the key determinant of these fractures are the number of articulation. As we know, we have 4 articulations of the zygoma, and the zygoma is discussed as, or is described, fractures are described according to the rotation and to the impaction. We are coming to this later on. The orbital blowout fractures, also the mid-face fractures, L4, 1, 2, and 3, the mandible fractures, the Naso-Orbito-Ethmoid and frontal sinus fractures. Let's start with the nasal fractures. Nasal fractures are very easy to diagnose. You find the patient with extensive edema of the nose, with visible deformity sometimes. Sometimes he came with epistaxis, peri-orbital ecchymosis. You may sometimes, especially in boxers, you find crepitus. They can tolerate this. Sometimes there is CSF rhinorrhea. The CSF rhinorrhea is different from bleeding by the halo sign. You let the patient secretion from the nose on tissue and then detect the halo sign around the blood clot. You must do intranasal examination to exclude septal hematoma. As we said, it's important. Treatment. Just first we will discuss the classification. There are very, very different classifications, but I find Kim classification, which is CT based, is the most appropriate because it discusses the deformity and the treatment. Type 1 is very thin. We have the nasal bones, the thin bone here, and the thick bone up towards the frontal bone. So if the thin bone unilateral without displacement, this is for conservative management. Type 2, bilateral thin bone with displacement, and this is further defined into 0 or O, no septal fracture, and S with septal fracture. Type 3, bilateral thin and thick bones with septal or without. Type 4 is complex with surrounding fractures. The treatment is closed reduction. Most probably we need closed reduction. Timing is controversial. In plastic surgery, we do it in the first hours or even after a day before edema is very much. Some favor waiting for 7 to 15 days post-operatively. I don't know, just it's institutional differences, but it's better to do it within first 2 days. It's difficult sometimes with edema, but it's better to do it than to do a full rhinoplasty to correct the problem. We use usually Walsham for nasal bones and Ash forceps for septum under general anesthesia probably, or local anesthesia. You may put external splint to support the nasal bones or internal splint to support the septum. Septal deviation may be corrected. Sometimes people favor the open approach, even if the patients have without septal, have nasal fractures without septum. They favor open reduction to align the bone correctly. Also, septal hematoma here is highlighted. Okay. We move now to the zygomaticomaxillary complex fractures. The zygomaticomaxillary complex, we know that the zygoma is a large bone, or a bone that has body and 4 articulation. These articulations are very important in 3D projection of the cheeks and mid-face. It's very important to be reduced correctly. How to diagnose it? We find malar flattening. The cheek is flat, maybe the lateral canthus, or there is dystopia. Dystopia means that the orbits are not on same level. Maybe infraorbital hypothesia. Trismus. Trismus occurs from impingement of the arch, the zygomatic arch, over the chronoid, so it doesn't move correctly. Or sometimes it's due to muscle spasm, the temporalis spasm. You may find diplopia or dystopia, as we said before. To diagnose, we must palpate for the articulations, the zygomatico-frontal, the infraorbital, zygomaticomaxillary, and the arch. Okay. Different fracture classifications are described. Usually we use the Zing classification, that is type A undisplaced or minimally displaced. We don't interfere. Type 2 or type B displaced and unstable, and type C displaced, unstable, and complex involves the different different articulations. So this is definitely, we diagnose by CT facial. We see if the maxilla or the zygoma is impacted inside or rotated, either external or internally rotated. The 4 articulations are in place or displaced. Then we come to the treatment. The treatment, the zygoma has different articulations, and that's why they have different exposure parts. First exposure is the Gilles approach. We say this is the arch fractures. Arch fractures, we just disimpact the arch to avoid its impingement on the chronoid or the temporalis muscle. So we do it through one or two approaches, Gilles approach or Kin approach. This is the Gilles approach. We open transverse incision or oblique incision in the hairline over the temporalis and then cut through the skin, superficial fascia, and just dissect till the deep temporal fascia, and then slide our Gilles reduce or our Bristow elevator. This is a huge instrument that can reduce the arch. We make the skull as fulcrum and push down on the skull to raise the arch. The second approach for the arch is the Keen approach. Keen approach, we go through the vestibule of the mouth and go directly over the bone under the arch, directly over the maxilla, slide it over the maxilla till we reach the part under the arch, and then reduces in the same way. Then we go to the Zygomaticomaxillary fracture, how to gain access to these fractures. First, the lateral blepharoplasty incision. We do lateral blepharoplasty incision and dissect through the orbicularis and then slide over till we reach the periosteum of the lateral orbital wall. This approach gains access to the lateral orbit and most importantly to the inside of the orbit at the lateral orbital wall, what we call the zygomaticosphenoidal point or zygomaticosphenoidal articulation, which is very important landmark to confirm how much or our reduction is fully reduced, our bone is fully reduced, or there is minimal displacement, as this part is 3D oriented. If it is displaced, so the zygoma is displaced downwards. If it is rotated, so the zygoma is rotated. We usually use the lateral blepharoplasty incision. It's better cosmetic than the lateral brow. Lateral brow is just incision under the eyebrow. It's very cosmetically unpleasant. Then we go to the transconjunctival approach. In this approach, we gain access to the infraorbital rim, the orbital floor, which is very important. So in this approach, we flip the eyelid over with suture retraction. Then we flip it over Gevernier or Desmart retractor and incise mucosa, incise the conjunctiva, and make a septal or a conjunctiva flap that may be anchored to the upper eyelid, suture to the upper eyelid or lid margin, upper eyelid margin, to avoid any accidental injury to the cornea, and then go either pre-septal, and this is better to avoid disruption of the septum, and then go pre-septal, then open the periosteum over the orbital rim, or go post-septal through the fat, and this is a difficult approach. The same thing we do in the subciliary, but subciliary we do skin muscle flap and then go pre-septal. The problem in the subciliary incision that it makes sometimes a scleral show due to disruption of the eyelid. Following this is the vestibular incision. This incision is lower than it should be. It should be higher than this to make a cuff of mucosa so we can suture the upper flap to it, and then we incise the mucosa and then incise the muscles and till the periosteum, and then incise the periosteum and go subperiosteal. This degloving flap degloves the midface. We may do it on one side or both sides, but keep a Z on the frenulum or some V, like a V on the frenulum, to avoid displacement of the mucosa. Two incisions that are less commonly used: the coronal incision, which is used mainly for comminuted fractures, and if you are going to fix the arch. If you're going to fix the arch, you should go through coronal approach. Sometimes we do pre-auricular approach, but it's very limited because the section is limited by the frontal branch of the facial nerve. It is for the root of the arch, and definitely for the condyle, but this is the maxillofacial fracture, zygomatic fractures we are talking about now. Okay, in the zygomatic fractures, we must rely on the CT and examine every articulation, and in sometimes not a must, we explore the orbital floor. You may explore the orbital floor if you find in the CT there is orbital floor defect, but if you are going to expose the orbital floor and dissect the orbital floor just to see without knowledge, it's very, very bad practice, because sometimes if there is minimal comminution of the floor, when you go through the orbital floor, you may displace the bone and make the problem worse. And sometimes we rely on the periorbita to support the eye. Later on, it's coming the orbital floor fractures. So we just sometimes we do combine all these incisions to get proper reduction of the zygoma. We do reduction, and as we said before, the zygomatico-frontal suture and zygomatico-sphenoidal point in the lateral orbital wall is very important to confirm the alignment, and especially the rotational alignment. Sometimes the bone is not displaced, but it's rotated. Then we do points fixation, 4-point fixation or 1-point fixation according. Usually we put at the nasomaxillary straight plate. At the rim we put orbital plate. At the zygomaticomaxillary we put L-shaped plate, but in the lower part of the L-shaped plate avoid bicortical or long screws to avoid going through the roots of the teeth. Exploration of the floor may be needed if there is diplopia, or by the CT there is large floor defect. The blowout fractures mainly occur in the medial and inferior orbital walls. The medial and inferior walls. Why? They are very thin, and the mechanism of the orbital fractures that there is blunt trauma to the eyeball, and the eyeball doesn't find anywhere to go except to hit the small and thin medial or orbital floor orbital walls. Okay, so how to diagnose it? There is ecchymosis, definitely, especially the raccoon eye. There is enophthalmos, may be delayed if there is edema. Diplopia, especially in upward gaze, mainly if there is inferior or orbital floor involvement. There is restricted movement, maybe some movements may be not proper, and this may cause diplopia. The problem sometimes is there is trapdoor fractures. What is trapdoor? The trapdoor is due to differential movements of soft tissues and bone. When the eye receives blunt trauma, the eye moves in everywhere and goes through the bone, that's the weak bone, most probably the inferior or orbital floor, and this causes prolapse of the orbital contents through the fracture. The problem is with the relapse or the contents coming again into the orbit. The contents doesn't come the same speed the fracture closes. So as if there is a door opened and it closes over someone's clothes. So is some contents of the orbital floor may be trapped inside the fracture. This may pass unnoticed, except there is a muscle, very important muscle, the inferior oblique. The inferior oblique is over, part of it over the floor of the orbit. It passes over the floor of the orbit, so it may be trapped. If this is trapped, the patient cannot maintain upward gaze due to entrapment of the inferior oblique, and in severe cases there is oculocardiac reflex. There is reflex bradycardia, severe nausea, and sometimes syncope when the patient tries to look upwards. This is an urgent and needs urgent operation to release the muscle before it is necrotic or it is dead and necrosed, because this entrapment presses on the blood supply and may cause its necrosis. The orbital blowout fractures, especially the floor, is important to reconstruct, especially if there is enophthalmos more than 2 millimeter, and this is done by exophthalmometer, or by CT we see large defect more than 1 centimeter on the scale, or non-resolving diplopia. There is diplopia with confirmed entrapment. You may go through transconjunctival approach and put either mesh, or sometimes we put cartilage graft from the ear, from the concha, or patient-specific implants. There is something called white-eyed blowout fracture. This occurs in pediatric fractures. There is minimal bruising. It's only trapdoor entrapment, and these children comes with inferior rectus, not inferior oblique, inferior rectus entrapment, and they suffer the same as oculocardiac reflex, bradycardia, nausea, and syncope. Let's come to the maxilla and the Lefort fractures, Lefort fractures or Lefort classification. Lefort classification, Lefort 1 is a horizontal transmaxillary. It separates the palate inferiorly from the mid-face superiorly. Lefort 2 is pyramidal, and it passes through the nasal bones, the maxilla, nasal bones, lacrimal bone, and then passes to the lateral side. It also posteriorly travels to the orbital floor and the tragoid plate. Lefort 3 passes over the nasal bones, and it is complete craniofacial disjunction, separates between the cranium and the face. Maxilla most commonly is conservatively managed unless you are going to fix with the zygoma. That's why we called it Zygomaticomaxillary complex. The mandibular fractures. Mandibular fractures are more simple and more easier, but their complications are more detrimental. The mandibular fractures are described according to their anatomical site: condylar, angle, body, symphyseal, and parasymphyseal. They often come bilateral and sometimes with combination like body and angle. angle and parasymphysial. They are also classified in favorable and unfavorable. This is defined as the segments, the favorable fractures, defined as bone segments lateral to the fracture line are tend to impact or to come closer to each other with muscle pull. And unfavorable fractures are fractures that tend to come away from each other due to muscle pull. And this is, they have a large diagram, just so tentative to just describe here, but we will jump to the diagnosis. First, malocclusion. Definitely there is malocclusion, except in part or segmental fractures. There is malocclusion, especially anterior open bite that suggests bilateral condylar fractures. There is sublingual ecchymosis. Definitely you will know it in the CT. You will know the fracture site. These are the common sites of the fracture: condylar, angle, body, symphysial, ramus. Okay, imaging, as you see, this is panorex and this is 3D reconstruction. The treatment is closed reduction with MMF, and this is reserved for pediatric fractures, mainly for pediatric fractures. Most probably in adults, we don't use only closed reduction, even if it is favorable. Then, according to the site of the fracture, there is different fixation modalities. Like symphysial fractures, we may use two leg screws put in the fracture, just reduce and compress the fractures. Definitely first, before you do any osteotensis or plate and screws, you do maxillomandibular fixation to fix the fractures or to get occlusion. The occlusion is very important. Then there are different sides, as we said. The symphysial, we may do two leg screws. The angle fractures, especially in non-violent adults, we may do Champi line fixation. We put the mini plate over the Champi line. It's over the upper border of the mandible at the angle. It just fixes the fracture. We have also two different types: load sharing mini plates. The mini plates are smaller and more malleable than the large, what we call reconstruction plates or 2.3 plates. The load sharing, it helps fixation of the fracture, but without loading the whole thing over the plate. While the load bearing reconstruction plates, we load all the fracture healing over the plates. When we use the load bearing, when we use it, if comminuted fractures, atrophic mandible, old age, we usually use load bearing, while most probably in adults we use load sharing many plates, and also load bearing in pathological fractures. Condylar fractures is very important as it's inside, sometimes outside, and sometimes inside the TMJ, so you must properly know how to treat it. In pediatrics, most probably we don't do MMF, we just give soft diet and follow up the patients closely, just every 2 or 3 days, to detect any malocclusion and behave accordingly. In adults, it's accepted to do elastics, especially, or we call it guided occlusion, we guide the occlusion to favor the healing of the condyle in a good position. Then we move to the Naso-Orbito-Ethmoidal fractures. Naso-Orbito-Ethmoidal fractures are fractures occurring in the orbital or ethmoidal bone and the orbit and the nose. That's why it has this Markovitch classification. It's single non-comminuted central fragment with the nasal bone fracture, or comminuted central segment, but the medial canthal ligament or tendon is attached. So number one, single non-comminuted with the medial canthal tendon attached. Type 2 is comminuted, but the medial canthal tendon is attached to a sizable bone fragment that can be fixed. Either this bone is displaced or not, but it can be fixed. Type 3 is severely comminuted central fragment with the MCT detached from the bone. Most probably they occur and they are diagnosed by telecanthus. Telecanthus is increased distance between the two canthi, or sometimes you found rounding of the canthi. One canthus is rounded, not sharply or angled. Bowstring test, we force or make lateral traction on the eyelid that reveals that the MCT or the medial canthal tendon is not attached. Saddle nose deformity, or what we call telescoped nose. There may be CSF rhinorrhea if there is cribriform plate injury with severe orbital edema. The orbital edema may obscure the injury, so you just must have the CT. The Markovitch classification, this is type 1, non-comminuted, non-displaced, the MCT is in place. Type 2, comminuted, or MCT is in place or attached to a large bone. Type 3, severe comminution with the MCT not attached or avulsed. Definitely, if you have bone to be reduced, you must reduce, and you can use either the coronal approach or less invasively medial canthal approach. We open it on both sides, as we can do transnasal wiring. Transnasal wiring is reattachment or passing of the tendon from one side, from the injured side, to the other side to be fixed on the other nasal bone, the other side nasal bone. So we must open bilaterally. This is a tricky question. You must open bilaterally. The frontal sinus fractures. Frontal sinus fracture